years, which I really think is the best telestroke program in the world. And working with my colleagues in the Middle East, in Turkey, and in the future I can be, inshallah, working with Dr. Aisha, Dr. Ayaz, and Dr. Hunayn on implementing this system. You can understand this system is very unique. And Dr. I think one of the representatives before virtual touch base on that program. So we have this province of Ontario, which is half size of Alberta. It's inhabitants of 12 million. 12 million inhabitants, multicultural, beautiful province. And in that program, telestroke has been developed. And the way it has been developed, there is a primary stroke centers, hospitals all across the province, on average 33. And we have a 22 consultant stroke neurologists, one take a call as a primary call, and one a backup call in case you get 2 acute stroke calls at the same time. And we take a shift 24 hours. And the way it works, we have a critical care line calls, central critical care line calls, where if patients come to one of the peripheral primary stroke centers or stroke-related centers, will be evaluated by the emergency physicians, call critical care line, will bring the telestroke physicians. This telestroke physician bring this card with a computer in front of the patients. I will assess this patient in the help of the emergency physicians. Then patients will be sent for imaging, and imaging will be sent to iCloud. I will review the images, decide on thrombolysis. And we will do CT angiogram. And there is a large vessel occlusions. I will call critical care line. I will bring the interventional center in that area, and with the primary stroke center will arrange transfer. So it's a hub and spoke models. And the way it works, in Ontario, we divide Ontario into 7 pockets of comprehensive stroke centers and primary stroke centers around. And we cover these areas. We cover 33 centers. And what we do, we start the thrombolysis. We do the assessment, stroke assessment, start the thrombolysis into the primary stroke centers, then coordinate for the patient to be moved to the hub, to the comprehensive stroke center for mechanical thrombectomy. And if you look at the data, it's marvelous. Now, you start step by step. My advice on telestroke, don't jump quickly and start crazy and all those things. In Ontario, in 2002, when I was doing my fellowship, when I just finished my fellowship, Ontario program started with 2 sites. In 2020, 31 sites of primary stroke centers. And now it's 34 sites. And you look at the number of consults, number of thrombolysis, how it's peaking up. So, and if you look at the data, in all Ontario, and thanks to Frank Silver, he shared the data with me, 1 in every 4 patients, 1 in every 4 patients receive TPA through telestrokes. So 25% in Ontario patients receive thrombolysis through telestroke. At the same time, 76% of Ontario telestroke TPA sites rely on telestrokes. 1 in 10 patients receive TPA will be sent for ADT, mechanical thrombectomy. That to understand the importance of these programs in the province. And it's the way I always suggest, I always recommend to get this program supported by the government. Because this is a big program. So really get it supported by the government is very critical. We did a meta-analysis. We asked the question, is telestroke more effective than conventional treatment for acute stroke? And actually, I have students, all what I do, I mentor them, guide them, and they get this meta-analysis done and I review it with them. Actually, we did that with the Zakaria and it's just got published in the International Journal of Stroke. He looked at over 1,300 of telestroke, of 1,300 of articles and abstracts and all these things, end up with 33 articles that use telestroke versus conventional treatments. And what we found, that included a good outcome, with a ranking scale 0 to 2 at 90 days, there is really no difference between both. So it is safe, it is good to use, there is no difference. We do not expect telestroke to be better than traditional treatments, And the mortality is very much the same, so it is same. And if you look at the symptomatic hemorrhage, it's very much the same between both treatments. I have to run the time. When I look at the critical time parameters, rate of thrombolysis, 30% versus 20%, 10% increased rate of thrombolysis by using telemedicine, which is very important. Now, thrombectomy less with telemedicine because you have a mothership. This patient with a thrombectomy in a small area, you might end up bringing them directly to the comprehensive